Thank you, and thanks very much, Thomas, for the invitation to present today. I don't have any disclosures to declare. So what I thought I might talk about today is looking first of all briefly at the burden of musculoskeletal pain, looking at various physiotherapy approaches that could be used. It's going to be a bit more of a focus on spinal pain, which is probably good because we've just had tennis elbow covered, and I tossed up whether to include tennis elbow in there, so luckily I didn't. And then looking for what's the current evidence for various physiotherapy approaches and what are new and future directions that are emerging. So as we've heard, the musculoskeletal pain is a huge burden. It incurs significant personal and economic costs, and particularly spinal-related pain such as whiplash and low back pain, and possibly one of the reasons for particularly the economic costs are related to the compensable nature often of these conditions. They have a high propensity to chronicity, to develop ongoing or persistent pain and related disability, of course, as we probably know. I think it's interesting with the 2010 Global Burden of Disease study that you could see there that low back pain is ranked first and neck pain is fourth as the causes of years lived with disability, and ahead of things such as diabetes, falls, arthritis and so forth. So this is a very interesting, I think, and very important areas that are incurring a lot of burden, but in real terms are much less studied, even though we're all here at a pain conference. The funding towards conditions such as diabetes, arthritis or cardiovascular disease and cancer is so much greater, and this could be one reason perhaps why we're not making such great inroads into these other musculoskeletal conditions that we perhaps could be. So physiotherapy, I thought I might just have a look at what some sort of interventions comprise physiotherapy, because it does depend a little bit on where you are, what physiotherapists do. So I just thought I might, just outline this a little bit first. So of course, one of the bases of physiotherapy is exercise and activity-based interventions in a broad term, I'll call them that. Things such as advice, education and reassurance, which physios do, of course. Then we have things, manual therapy or manipulation, some people might call it, although there are subtle differences between them. Also looking at psychologically informed interventions, and I'll look a little bit about this today. So physiotherapy, I think, is moving away from a totally physical rehabilitation approach to looking more at, I guess, the so-called biopsychosocial model, if you like, and taking some of these types of interventions on board as well. And I'll show you some data from some of those studies as well. And then lastly, we have other modalities, the passive modalities, the electrotherapy, the massage and so forth. I'm not going to touch a lot on that today because, as you've probably already heard, it's similar to with spinal pain conditions, that there's not very much strong evidence for sort of passive interventional approaches. So again, depending on where you live in the world and depending on jurisdictions, physiotherapists can be a first contact practitioner. In some areas they can order x-rays and imaging. Some have limited prescriber rights. Some have even limited or sickness certification rights. And what we call this is an extended scope of practice. And some of these things are more prominent in some areas at the moment, such as the UK, in Australia. That's moving towards this. And the reason for this, of course, is to spread the health dollar more effectively, more efficiently, so that physiotherapists can take on greater roles, particularly in regard to musculoskeletal pain. So this is something I think we need to think of then, if extended role practice is to spread more throughout the world, that what our traditional physiotherapeutic techniques are probably going to change somewhat. However, in some areas it's still by referral and only by referral, and in some areas of the world still, I think there's still quite a lot of is dictated to the physiotherapist, probably from the medical practitioner, as to what interventions they should provide. So again, this sort of differing roles throughout the world can have implications for our understanding, I guess, of the effectiveness of various physiotherapy approaches. Let's have a quick look, though, at the current evidence for some conditions, and this is very brief. So first of all, looking at acute non-specific low back pain, there's various guidelines, clinical practice guidelines throughout the world. and they generally agree, but there's some slight disagreements here and there, but in the whole overall scheme of things, they generally agree that the first line of care should be advice and reassurance about the condition not being a serious one, reassurance that the people can resume activity, and so forth. Okay, we still don't really know, though, what reassurance is, or what's the best way to deliver it, or what we should be telling people. This is assumed. Okay, so that's an area that is undergoing some research. Simple analgesics, and then to remain active. And then if the patient isn't recovering, then perhaps looking at second line care of evidence for manual therapy. Guidelines disagree to some extent about the role of exercise in acute low back pain. I mean specific exercise, not general activity, and returning to their activities. And there is some evidence for the application of heat. And then, of course, there should be no routine x-rays, and the person should avoid bed rest. With regards to persistent or chronic low back pain, if you like, non-specific low back pain, then the interventions for this and the evidence, this is the evidence, but the interventions vary because some people can present with quite a simple presentation as opposed to other patients that may have treatment at a pain clinic. So down the simple end, we often have community dwelling patients that aren't in need of a pain clinic but are commonly seen by physiotherapists. So the interventions can vary, again, from rather simple, straightforward interventions up to multidisciplinary treatments, and then in the middle, other things as well that show some evidence at the present time. The evidence for exercise or specific exercise is stronger in persistent or chronic low back pain than for acute low back pain. And again, not routinely ordering imaging techniques and avoiding bed rest. One of the reasons for perhaps this continuum or difference between presentations, as I've mentioned in low back pain, is that the trajectories of recovery of low back pain tend to show this episodic nature. So it comes and goes. And in some people, perhaps those comes and goings may be more frequent. They may be more persistent, and this could explain perhaps how we see some patients that we see community dwelling patients as opposed to others that need and seek more intensive interventions and multi-professional management. If we look at neck pain now, and specifically whiplash, the guidelines, and of course these are based on the current evidence. These are the most recent guidelines, which the Australian ones that have just come out again and been revised. And again, the recommended treatments here you can see is very similar to low back pain, isn't it? Advice to remain active, reassurance this time about that symptoms are a normal reaction to being injured, that they maintain a normal life is important, and it's important to focus on improvements in function. Now again, around reassurance, this isn't strong evidence. There is evidence for reassurance, but again, we're not sure how that should be delivered or what the patients really want to know or what they need to know. Also looking at neck exercises, so the guidelines, the evidence would suggest that specific exercises trying to maintain range of movement, muscle control, endurance and strengthening are important as well. And we come down to the first line, pain relief, which again, as I said, is not traditionally medication, pain relief thought of as a physiotherapy domain, but with first contact practice and so forth, physiotherapists often making suggestions or recommendations to patients about these things. With regard to whiplash then, the guidelines also suggest that things such as manual therapy, manipulation, acupuncture and so forth should be used with caution because there's very limited evidence. There may be some evidence, but it's fairly weak. There's some interventions that have been shown to not be effective, and you can see them there. So botulism, toxin, muscle relaxants, pulsed electromagnetic treatment and so forth. And then this whole list under the grey heading there where there's really no evidence one way or the other with regards to things such as traction, other techniques, other exercise activity techniques, I guess, such as Pilates, Feldenkrais and so forth. We don't really know what the effect of them is at this point. So the clinical guidelines are of course based on systematic reviews, and the summary of this one was that there is the strongest evidence for activity in exercise, in acute and chronic whiplash, but the effects are modest. And that there's, for chronic whiplash, again, there's, with rehabilitation approaches, that the effects are modest also. And another recent systematic review came to the conclusion that most studies have small effect size, suggesting that a small clinical effect can be expected with the use of exercise alone. And this is similar to low back pain. So even though activity and exercise is better than the person going to bed in the case of low back pain, or wearing a collar in the case of whiplash, the effect sizes are, I would say, modest at best, or small. I guess that's similar for a lot of interventions for these sort of conditions, but it's not a panacea. People are better keeping active, but we still need to know more in order to have better outcomes. Just a couple of recent studies that are quite interesting, I guess. One in the UK, the MINT trial, in acute whiplash, that showed that a package of physiotherapy, which included 6 to 8 sessions, was somewhat better than a single physiotherapy session, but it wasn't cost effective from the UK NHS perspective. Okay, so we're looking now more at more intensive physiotherapy interventions versus 1 or 2 sessions. Okay, and there wasn't a lot of difference with that study. We've also took a study in chronic whiplash, and again this was comparing a 12-week rehabilitation program which included motor relearning, it included then transitioning to more graded activity, and included aerobic exercise tailored to the patient's fitness levels and what sort of exercise they like doing over 12 weeks. And we compared that to act as usual, I guess, which was one physiotherapy session where the physio could describe the exercises to the patient and provided them with some information, but that was all. And then they could have a follow-up phone call. So just 172 people in that study. And you can see the differences. On the top graph is pain, on the bottom is disability. The difference between the 2 interventions, there wasn't one really. Although we should note that both interventions, there was a decrease in the symptoms, okay, decrease in pain, coming down, and a little bit in disability. This is probably clinically relevant, about a 10% change on the Neck Disability Index, and plateauing out. So some improvement in both conditions, but a comprehensive 12-week physical rehabilitation program wasn't any more effective than a single session of physiotherapy and advice. And these are just the treatment effects there, which I won't dwell on too much. So one of the things that's captured the interest in this area, I guess, is these are RCTs, and again, this is group data. So, are there some people that respond to physiotherapy approaches and others that aren't? That's likely. And people have started to look at this factor of what sort of factors may predict a response to physical activity or physiotherapy interventions. And there's a few things that come out. So for low back pains, the person who reported that their back felt unstable predicted a better response to motor control type exercises. And then but down the bottom there, a sheet study that they didn't find any of these factors here they looked at could predict response to McKenzie type of exercises. With regards to whiplash, we did a trial, an earlier trial in chronic whiplash with a multimodal physiotherapy approach compared to self-management, which showed a greater effect overall, modest effect. But in those with this sensory hypersensitivity, with mechanical and cold hyperalgesia, similar to what Thomas presented to you earlier, they didn't do as well, as you can see, with the multimodal management. So we thought that perhaps people with this widespread hypersensitivity or evidence of central or augmented central pain processing mechanisms may not respond as well to a physical intervention. In the later RCT, though, this was a post hoc analysis, but in the later RCT that I spoke about a minute ago, we a priori built in some effect to some baseline factors to see if they would moderate the effect of treatment, and nothing came out as being significant. So here we have things such as the SLAN score, we have pressure pain thresholds at various sites, We've got cold pain thresholds here, pain catastrophizing, how long they had their symptoms, post-traumatic stress symptoms. We couldn't find anything clear-cut as being able to predict who would respond and who wouldn't. So this is a little bit sad, really. This is an area that I think needs to be explored a little bit more in depth, that at the moment we may think or predict that some people may respond and others don't, but we really don't have a lot of evidence as to be able to identify who they are. If we look at neck pain in general, on the left there you have acute whiplash, which I've talked about, but also non-traumatic or idiopathic type of neck pain. There's slightly different evidence for various interventions, as you can see there. It has been argued that idiopathic neck pain is a different kettle of fish to whiplash, and I would probably agree with that. We saw a study that Thomas presented on that we did, Scott et al., where we showed a different sensory presentation between the two neck pain groups. Unfortunately, though, some guidelines around the world want to group these two conditions together. I think there's probably different processes underlying them. We've seen that in one study, which has been repeated a couple of times now, but also that there seems to be different response to different treatments. And so there may be different underlying processes with these conditions. I haven't talked, as I said, I wanted to focus this talk on spinal pain because it's big enough as it is. But if we have a look at just briefly at arthritis and a review of the management of physical therapy management of arthritis, then we get a similar sort of picture that passive modalities such as manual therapy, TENS and acupuncture are not particularly not having clinically important response. Things such as orthotics and things in shoes at the moment are unlikely to provide clinically important benefits. And compared with not exercising appears to be a moderate benefits of exercise, but the optimum prescription and dosage of that exercise isn't clear. And that exercise may delay the need for joint replacement, but that needs to be further verified. And so again, we're getting this similar sort of picture that exercise is probably good. It has some effect. It's better than non-exercising, but the overall effect size is still quite small. This study also alluded to, I think, the important thing with regards to exercise is that we know that exercise is better than not doing it, but we don't know what's the most effective form. Various studies use various different forms of exercise type. The dose isn't standardised. We don't know what intensity is good. We don't know how much is good. We don't know if one form of exercise is more effective than another. For example, strength training, motor control retraining, aerobic type of exercise, more functional exercise. We could go on and on and on. At the moment, we don't know the answers to those questions. So as I said to start with, some of the areas that physiotherapists are moving into more is looking at physios to deliver more psych type of interventions as well. And this is, of course, in regard to the findings that physical rehabilitation effects are small, and that, of course, with the biopsychosocial model and yellow flags that we've heard about, that we probably need to take into consideration these factors as well. And particularly in primary care, it's often not feasible to see a psychologist via various public funding models in different countries and so forth. In acute injury, for example, whiplash, patients, when RCT we didn't want to see a psychologist. They thought, well, you know, rightfully so probably, that their injury is in their neck. It's like having a sprained ankle. Why do I need a psychologist a couple of weeks out post-injury? They couldn't quite see the importance of that. They may see it as they don't recover, but in that early stage they didn't want to go. Aggressive psych interventions such as psychological debriefing after an injury or after trauma might be detrimental. And so there is an argument that physiotherapists are placed to deliver psych-type interventions, particularly in acute injury, but also in the chronic musculoskeletal pain as well. And there have been a few studies looking at this in this regard. Kim Burnell and my colleagues have looked at it in chronic arthritis. This is the results of a pilot study. They have completed the full trial, but I don't think, I couldn't see it. It must not be quite published yet. So they found that when the physios delivered combined exercise and pain coping skills training, there was improvements in physical outcomes and also psychological outcomes. Another group looking at chronic low back pain, Peter O'Sullivan in Western Australia, where they do a classification-based cognitive functional therapy, they call it, which is delivered by physiotherapists. So the physios are trained to deliver a cognitive component in addition to the exercise, and they compared that to manual therapy and exercise alone. And they got quite good effects, as you can see there. So if we have the primary outcome variables of the oswestry, that the combined cognitive approach was more effective. This is a clinically relevant difference on that questionnaire, and similarly for pain as well. So this is quite good that they're getting clinically relevant changes with this intervention, because it can be quite difficult to get any effect, as you could see from the chronic whiplash trial published, the PROMISE trial in the Lancet. And of course, probably the most commonly form of this sort of intervention that you're aware of is the start back tool in the UK, where the patients are stratified based on their risk of developing chronic symptoms or not, and then the treatment is tailored towards their intervention. So after completing the start back risk assessment tool, the patients are classified as either low, medium or high risk of not doing very well, and then the treatment is tailored towards these various stratification factors. So those with low risk receive advice and reassurance and some medication, ranging up to those at high risk, where again the physiotherapists are trained to deliver a psychologically informed intervention in addition or integrated within the physiotherapy exercise approach. And the results of this study are quite promising, as you can see. So we have here on the far left the overall effects of the trial. Okay, so the red group, where they provided the stratified treatment. This is the effects in the low risk group, the medium risk group and the high risk group. So again, getting clinically relevant changes, stratifying the patients on via their risk factors. So I think this is sort of one of the ways that perhaps we're moving forward in trying to be able to, specifically in the acute injury stage, stratify people on their risk and then provide treatments targeting towards those factors. The other thing it tends to avoid at least in the low risk group, is providing too much treatment that may be iatrogenic. Okay, and there is some evidence, particularly in whiplash, that too much early treatment may not be a good thing. But who do we give the treatment to? And these sort of approaches are starting to try and develop that. We've also developed recently in whiplash a clinical prediction rule with a similar aim for the start back tool, but it seems things have come out slightly differently in terms of what's been included in the model. So we've done quite a lot of predictive work and have included various variables over the years. So we tried to analyse these into a clinical prediction rule. And again, what we found was that using the Neck Disability Index score, those with greater than 40% on that, and then I'll talk about this scale, greater than 6 on the hyperarousal scale, age over 35, with quite good specificity of about 90%, we could predict those with chronic moderate to severe symptoms. We could also predict those at low risk, and in the group in the middle, whiplash was never going to be black and white. We have a group that we called medium risk that could go one way or the other. But what we're trying to do here again, and this is aimed at primary care, I guess, for physiotherapy intervention, but also for doctors, is to be able to think about who looks like they're going to do well and who looks like they may not be going to do well, and what can we do about those people, rather than treating everybody as a homogenous group. This is the hyperarousal scale, so it's a subscale of the post-traumatic stress diagnostic scale, and this was the hyperarousal symptoms came out as the strongest predictor. So when I talked about a score of greater than 6, it's basically on this tool. So what we think are the implications again with this is that people at low risk, minimal intervention. What we would suggest for GPs perhaps, or doctors using this tool, is maybe they need to refer the patient to someone with expertise in the assessment and management of whiplash, whether that be a physiotherapist or somebody else. And these people would need further assessment on their nociceptive processing, what's happening there, on their psychological factors, psychosocial factors, and look in more depth of their motor control and their movement and so forth, their movement activities. In this group, we would watch them. As I said, they could go this way or that way. So just summing up of what I've tried to say to you today about where physiotherapy's at and where it's going with regards to musculoskeletal pain, that predominantly physical rehabilitation approaches only seem to have modest effects. But I guess, is this so unexpected when we know the complexity, particularly of the people with the chronic musculoskeletal conditions? Physical rehabilitation alone may be effective in some, but we don't quite clearly identify who they are yet. The treatment effect modifiers aren't clear. But this subgrouping or classification process, particularly in the acute but also in the chronic scale, seems to show some promise. And this is probably where things are heading at this point in time. But people still need activity and exercise. We know that's important to prevent other health complications and other health conditions. So people with acute or chronic pain, they still need to be doing activity. So one of the other things that may need to be considered, as I've outlined, is to address other factors, such as psychological factors, and something else that hasn't been looked at is nociceptive processing and trying to combine various medications with the physical rehabilitation approach to try and enhance its effectiveness. Thank you.
Thanks very much for an excellent lecture. Do we have any questions? Very quiet. So it was also very clear. But if that's not the case, then I would like to use the opportunity to thank the three colleagues here who gave the presentations. I think that we covered many different issues here today, and we got all the way through the musculoskeletal area. So thank you very much for coming, and enjoy the meeting.